this immunization, this sensitization. So that's why mama are going to be always tested for blood type. If the blood type is Rh negative, need to be injected with a substance called Rogan. Rogan is something injected that hide. You know what is hiding? Occult, hide, occult, hide any positive Rh red blood cell that could enter in the body of mama. So if in one day in the pregnancy enters in the body of mama one red blood cell positive, this Rogan take him, hide it, come here, hide. We don't want mama to see you. And they hide these positive Rh red blood cells. As a consequence, mama never will discover that exist positive Rh, red blood cells, and will never produce antibodies against this type of blood cells. Make sense? Okay. When is given Rogan? Mid-pregnancy, okay, like in the week 24, 26, yes, mid-pregnancy, pregnancy 40 weeks, yes, mid-pregnancy, yes, Rogan. And again, moment of birth are two moments in which need to receive Rogan. So if mama is Rh negative, will receive 2 shots of Rogan. Mid-pregnancy, around 24-week gestation, and at the moment of birth. No problem with that. You can remember that. Okay, can mama receive more than 2 shots? Yes. If there is any trauma, you know what is trauma? Yeah? Any trauma that could produce, this trauma could produce transference or translocation of positive baby's red blood cell to negative blood of mama, yes, then need to be added another dose. Suppose mama is falling from stairs. It's a trauma, yes. It need to be given an extra dose of Rogan. Suppose mama, I don't know, fights with another person and receive, some hits in her belly. Yes, because it was in English, domestic violence in a pregnant woman that was Rh negative. What else could be a trauma? A amniocentesis. What is that? It's a trauma because they pierce the abdomen, the uterus, with a needle. It's a trauma, no? Those are examples of trauma. So now each time the woman has an amniocentesis, trauma, whatever, another extra dose of Rogan is going to be given. Any problem with that? Okay. These Rogan must be given also in miscarriages and in abortions. Okay. So after miscarriage and abortion. Are we good? No problem? So everybody knows what is Rogan. Everybody knows when need to be given, and everybody knows to whom must be given. Do we need to give Rogan to Rh positive mama? No, not necessary. Point apart. What is Coombs? Coombs is a blood test, like hemoglobin, creatinine, or BUN. Yes, it's a blood test. And for what is this blood test? Is to determine if mama is already producing those antibodies that we don't want to be produced. Do you remember that I said if a positive red blood cells enters the body of mama, mama start producing antibodies against positive red blood cells? Yes? Okay. We can detect in mama's blood if she is producing those antibodies already. When we don't know, we ignore the status of a woman who is Rh negative. This kind of precautions is for Rh negative women. Then we test, a part of testing the type of blood, we test her Coombs situation. If she is producing antibodies, the Coombs is positive. If she is not producing antibodies, then the Coombs is negative. Okay, so what is a Coombs positive? mama is already producing the antibodies. So something failed there in any moment in the past. Somebody forgot that a Rogan needed to be given, and she finally discovered, okay, those positive Rh cells, and is already producing antibodies. It's too late. What means that the Coombs is negative? Oh, we are on time. It's good. It's good. Why? Because she doesn't know. She still doesn't know. And we can still hide the positive rebel cells. So what is the best scenario in an Rh negative woman? That Coombs be negative. The test of Coombs can be done in mother and in baby. If it is done in mother, it is order Coombs indirect Coombs test. If it is the order in the baby, it is order in the paper, and the request is direct Coombs test. Acedito, okay? Very well. So who must receive Rogan? In the middle of the pregnancy, at the moment of birth, or in any trauma possible. Women that are Rh negative and Coombs negative, okay? These are the women that should receive the Rogan. If the woman is Rh negative, but is already Coombs positive, is not worthy, is not helping, is not the logic given the Rogan, because you cannot hide something that she already knows. You understand? Okay. So that's it. This is the interpretation of the Rh compatibility and the questions about the Rogan and the interpretation of the Coombs. Any question? What recommendation should be given to a client diagnosed with high datiform mola after dilation and curettage? You can have children because hysterectomy will be required. Mola is a malignant condition which requires chemotherapy with methotrexate. You will have to prevent pregnancy within 1 year, and mola is a benign condition and no longer follow-up is required. What is for you the best answer? C as in cat. Okay, C as in cat. Mola is benign, is not malignant. Yes, and mola is treated with a curettage. And after 1 year of the mola, the woman can become pregnant, but cannot become pregnant before 1 year. So need to avoid pregnancy in the first 12 months, the first year after the mola. Very rarely, mola can produce cancer, but late after the mola. It's called choriocarcinoma. And doctor will follow all clients that had a mola are followed for 1 year, are followed with a blood test called HCG, or human chorionic gonadotrophic hormone. And if this substance elevates, then they investigate the possibility of the choriocarcinoma. This substance, the HCG, also elevates in pregnancy. If the woman becomes pregnant, then doctors can't know if the woman is having the choriocarcinoma or not. That's why the woman should not become pregnant in 1 year. We don't know why mola happens, but it is a chromosomic problem. Is an egg, okay? Is an egg, female egg that has no chromosome, has no nucleus, and is impregnated by sperm, and as a consequence, because they are lacking chromosomes, a baby cannot be produced. But what can grow is the tissue that would produce the placenta, the trophoblastic tissue. Grows too fast, grows too uncontrolled, is benign, and what the woman is going to feel is, first, is going to feel that is pregnant. Second, the uterus is growing too fast, faster than expected, bigger than expected. So a finding is a belly that is too big for the gestational age. Third, it produces a huge amount of human chorionic gonadotrophic hormone, and this hormone produces a lot of nausea or morning sickness, so a lot of morning sickness and vomit. And thus can produce bleeding. Is diagnosed by ultrasound. The treatment is curettage. The uterus is left like new, but in 1 year should not become pregnant. This is the most important to know. The nurse is triaging clients at the prenatal service. Which client should the nurse see first? 34 weeks, bilateral pedal edema. 28 weeks, intense heartburn. 32 weeks, didn't show at last 2 appointments. 28 weeks, recurrent non-painful uterine contraction. Which patient should be seen first for your point of view?
B.
Okay, the intense heartburn occurs frequently in pregnancy because 2 reasons. First, the growing uterus produces a mechanical compression of the stomach, and then the acid of the stomach will regurgitate or reflux to the esophagus. The other reason is that progesterone, a hormone that is produced in huge amounts in pregnancy, relaxes the lower esophageal sphincter. This is a circular smooth muscle that closes the lower esophagus, preventing the acid of the stomach returning to the esophagus. So heartburn is a benign condition in pregnancy. B as in boy. Okay. D as in David. Okay. After 20 weeks of gestation, it's normal to have something called Braxton Hicks contractions. What define the Braxton? Okay. What define the Braxton Hicks contractions is they are not painful, and if the patient starts walking, disappears, or if the patient empties the bladder. So if the woman is concerned or annoyed by the Braxton Hicks contraction, tell her pee more frequently and walk, and will disappear. So now for ruling out, by elimination, that we need to look in this question something very concerning. Yes, very concerning. So we can eliminate 28 because it's a benign condition, and also D because it's another benign condition. This is Braxton Hicks, this is heartburn. Which one also is a benign condition here? A. A is bilateral pedal edema. We already discussed last week that ankle and pedal edema is expected in pregnancy, especially at the end, okay, in the last trimester. So need to be C, okay? What do you think is going to be the problem with C? We don't know, and that's the problem. Could this woman that has not been, controlling, assisting, being seen for a while, could be having a problem? Yes, it's a Pandora box. We don't know if the woman is okay. We don't know if this woman has high blood pressure. We don't know if this woman has high blood sugar. We don't know if this woman is having any problem. So by ruling out, by elimination of benign condition, and by the concept that all we must have, that pregnancies should be regularly controlled, because sometimes during pregnancy appears complications that are detected, and preferably early detected during those control. A woman who has not been assisting to their control, their appointments in the last 2 months, could be the woman with problems. We already mentioned last week what is a risk factor for pregnancy, and we concluded low income, low economic income. We discussed this topic, and we discussed the association between income, culture, education, insurance, availability, etc. Yes. So here we have an extension of this question. Is clear now? Can we move? Yes. So develop this kind of critical thinking. Strategies eliminate what you know is expected in pregnancy. And then know that if going to the doctor every month or every 15 days at the end is important and you don't go, it is an issue. That's the rationale of this question. Clear for everybody, no? We can move. Okay.
Yes, Professor.
Okay. The nurse is taking care of a newborn from a type 1 diabetic woman who had elevated A1C during all the pregnancy. So what we have here is a type 1 diabetic woman who became pregnant. So she was diabetic since whatever, and she wanted a baby and she became pregnant. The only problem that she is not controlling too well her diabetes, and for that reason her A1C has been high during all the pregnancy. No good control. The nurse knows that this child is at the risk of hyperglycemia, hyperkalemia, hyperbilirubinemia, hypercalcemia. Which of these hypers you think could be present in this child?
A.
I don't know what happened. I don't know what happened with the sounds. I do and I understood do and I didn't know the word. And I think the other one said C. Okay. Okay. The right answer of this question is C. Okay. The baby is going to have hypoglycemia. This baby, when it's born, will have hypoglycemia, no hyperglycemia. Why this baby will have hypoglycemia? This baby, while in the uterus, inside the uterus, is receiving huge amounts of glucose from the mother that has high glucose. As a consequence, we discussed that last class. As a consequence, the baby will have a huge amount of insulin. Yes, that's why those babies grow so big, macrosomic. Okay, has a lot of calories, a lot of food, and a lot of insulin. Insulin is an anabolic building hormone. Yes. Okay, now the baby is coming out of the uterus. Now the baby is out of the uterus. Yes. In the moment of coming out, has high glucose and high insulin. Yes. But what happened? They cut the umbilical cord. So what happened now? The glucose ran out because no more glucose coming from mama, but the insulin is still high. So now what we can have? Hypoglycemia, okay? And then we have this serious complication that can damage the brain of the baby, produce seizures, etc., in which at the beginning we see the baby with tremor, with jitteriness, and then the baby can have brain damage. Yes, that's why the babies of diabetic mothers need to be checked with capillary blood sugar and should have early feeding, okay, to prevent the hypoglycemia. Potassium has nothing to do with the hyperglycemia in pregnancy. This is not related. Potassium is not affected, neither up nor down by diabetes and pregnancy. But it is well known, and it's difficult to explain the cause, but need to be memorized by you, that classically and tested in Nclex, calcium in newborns from diabetic women, okay, is low. So the baby has hypocalcemia, hypocalcemia. What happens when the baby has hypocalcemia? They don't have this Trousseau and Chebostek that are seen in adults because they cannot have this manifestation, but they usually have seizures because low calcium produces seizures. Okay, so they have seizures because low calcium, and they can have also cardiac dysrhythmias. Remember that low calcium, a part of the Chebostek and Trousseau signs, produce seizures and produce dysrhythmia. So it's not hypercalcemia, it's hypocalcemia. So I rule out this, I rule out this, and I rule out this. So it's hyperbilirubinemia. The incidence of jaundice, neonatal jaundice, even without blood incompatibility, having the same type of blood without problem with the blood, is more frequent in children of more diabetic mothers when the diabetic mother is not well controlled in pregnancy. So macrosomia, hypoglycemia, hypocalcemia, respiratory distress because immature lungs, yes, are manifestations of a child of diabetic woman that has no well controlling her pregnancy. Remember that you have two situations. Remember, you have two scenarios in diabetes and pregnancy. Please think about this. Scenario number one, the woman is diabetic before becoming pregnant. Is a woman that is diabetic, okay? As millions of diabetic women are in the world. And the woman wants to become pregnant, yes? So this is one scenario. The other scenario, okay, is that the woman is not diabetic, but after becoming pregnant, after the mid of the pregnancy, after the half of the pregnancy, becomes diabetic in the pregnancy. And after having the baby, after delivering the baby, the diabetes disappeared. In the first case, it is diabetes mellitus. In the second case, it's called, gestational diabetes. Two different scenarios. What should do a diabetic woman? Type 1 or type 2 is independent. Type 1 or type 2 that wants to have a baby. First, need to control well her diabetes before becoming pregnant. And the only way that the pregnancy, the diabetes can be controlled to become pregnant is with insulin. So if the woman is type 1, must be necessarily mandatorily insulin. But if she is type 2, need to stop all the pills that you could be taking and need to change to insulin. Because the only hypoglycemic medication that can be used in pregnancy is insulin. Can be used metformin? No. Can use glipizide? No. Can use pioglitazone? No. What can use? Only insulin. Any type of insulin. There is not specifically a limitation in the type of insulin. Any type of insulin can be prescribed in pregnancy. Regular, rapid, NPH, Lantus can be prescribed, but must be insulin. Yes? But the day of birth, the day of the labor, then they need to only use regular, because any client that go to surgery, to labor, or is unstable only can use regular insulin. Yes? But before that, in the previous 9 months, any type of insulin, but only insulin. Okay? Very well. So what you need to know with a pregnant woman who wants to have a baby. Okay, after she's well controlled with insulin, doctors say, okay, you can start, you can have your baby. Now she becomes pregnant. You need to know, because it's tested, what happens with this dose of insulin that the woman was receiving before becoming pregnant. At the beginning of the pregnancy, in the first trimester, yes, the needs of insulin are going to drop. So the woman needs to reduce, lower, decrease the amount of insulin that is injecting. And the risk in this first trimester is hypoglycemia. It's tested. It's tested exactly as I'm telling you. So what happens with a diabetic woman that is injecting insulin and becomes pregnant in the first trimester? The needs of insulin are going to decrease. The dose of insulin must decrease, and the woman is at risk of hypoglycemia at the beginning of the pregnancy in the first trimester. No problem with that. But then, beginning the second and third trimester, everything is going to turn in the other direction. So now the need of insulin will start increasing, the dose of insulin will start increasing, and the risk of developing hyperglycemia. Okay, so there is this curve that before pregnancy, this is the need of insulin. Become pregnant, the need of insulin decrease. And then as the pregnancy grows, this increase. What happened the day of the birth, the day of the labor? The needs drops violently. So the day of the labor, there is risk of hypoglycemia. Yeah. And then normalizes as previous the pregnancy, but each day, each moment of the day that the woman is going to breastfeed, give breast milk to the baby, no? Breastfeed, then there is a risk of hypoglycemia. So before each breastfeeding, the woman should have a snack to prevent hypoglycemia. So hypoglycemia can occur in the moment of breastfeeding? Yes. Everything has been tested. All these have been tested. So those are in relation of the need of insulin of a woman who is diabetic. What happens in gestational diabetes? Some women that are not diabetic can develop diabetes during the middle of the pregnancy. Who are those women? They are older than usual. It is said usually older than 25. They are fatter, okay, more of fat than usual, has a BMI more than 30. They have family history diabetes, because gestational diabetes is a variety of type 2 diabetes. And probably they had in the past previous babies, previous children, very heavy, weighing more than 9 pounds macrosomic. Those are the risk factor for gestational diabetes. What doctors do in pregnancy to detect, to discover, to screen gestational diabetes? At the middle of the pregnancy, around 24 weeks, at the middle of the pregnancy, they give the woman in the doctor's office at any time of the day, morning, noon, afternoon, or night, when the woman go to the appointment. Yes, and the woman does not need to be fasting. So there is no need of fasting for this challenge glucose test, okay? And the woman is going to drink a cup of 50 grams of glucose dissolved in water. And they do a capillary blood sugar, an NACU check 1 hour after the woman drank this glucose. If it is 140, 140 or more, then the woman need to do the next day or the other day, need to go to the lab to do a complete glucose tolerance test. If it is less than 140, there is no need of the glucose tolerance test. The glucose tolerance test made in the lab, this is fasting, this requires, glucose before the administration of the oral glucose, and then 1 to 3 hours later. This is, you don't need to know those details. But what you need to know is that the glucose challenge test that is done by the doctor is not done by the doctor. It's done by the nurse. It's done ambulatorily. The woman doesn't need to be fasting. It's done the mid of the pregnancy, 24 weeks more or less, and is just drinking glucose. I could check 1 hour later, and if it is 140 or more, then is when the doctors sent the complete test of glucose tolerant test to rule out gestational diabetes. Majority of the patients with gestational diabetes control with diet without the need of insulin. Okay, so they can ask you which is the member of the multidisciplinary team that need to be referred a patient with gestational diabetes first, and is the dietitian. Is clear? No problem. Can we move? Nurse received 4 phone calls from pregnant women in their last trimester of pregnancy. Which call should be answered first? Client can sleep supine because shortness of breath. Client with frequent heartburn again. client who can't remove wedding ring, and client with frequent non-painful uterine contraction. So now, based on what you know, you can rule out D because you already know that, and you can rule out B because you know that, okay? And you should know that a woman that is in the last trimester is just almost finishing the pregnancy when adopts the supine position is going to experience shortness of breath because the mechanical compression of the uterus. So also you can eliminate this option because you should know this, you should know this, and you should know this. So it need to be C. What you suspect in C is severe edema. It's important edema. So the pedal edema, the ankle edema is okay, but edema in the face, edema in the hands is not okay. Make sense? It's just simple like that. It's an issue of quantity. And when we have this level of edema, what disease we suspect?
Preeclampsia.
Preeclampsia. Exactly. Preeclampsia. Okay, so the pregnancy-induced hypertension is a hypertension that appears for first time after the 20th week of gestation, and is a very complex pathophysiology, extremely complex pathophysiology, in which there is a malfunction of the microcirculation, the blood vessels in the placenta and the uterus, and there is a problem also in the microcirculation in the kidneys. So a part of the high blood pressure, we are going to have proteinuria. I mean, loss of albumin in the urine through the glomerulus, and a significant edema. So when the edema, affects the hands, affects the face, etc., trying to see those pictures here, it is something serious, and is the meaning of the previous question. A woman that have those conditions are declared to have preeclampsia, and if they are not properly cared, can evolve to seizures, brain edema, detachment of the placenta, okay, abroxion of the placenta, disseminated intravascular coagulation, and can die. And this, when the seizures appears, is called eclampsia. That's why it's called preeclampsia and eclampsia. We don't want the seizures, and that's why those clients, okay, when they have severe preeclampsia, they are initiated in magnesium sulfate to prevent the seizures. The preeclampsia can be mild or can be severe. It is going to be defined mainly by the level of blood pressure. Yeah, a level of blood pressure that is below 140 over 100 is considered mild, but a blood pressure that is above 140 over 100, okay, is a moderate to severe form of preeclampsia. There are other criteria, but it's the most important. A woman with a mild preeclampsia can be managed ambulatorily with, diet, rest, and surveillance. But a woman with severe preeclampsia is going to be hospitalized and is going to be receiving magnesium sulfate to prevent the eclampsia. The magnesium sulfate is just to depress, to decrease the activity of the nervous system, to prevent the seizures. So the reason for giving magnesium sulfate is not for the edema, is not for the blood pressure, it's just to prevent, to avoid the seizures. The woman is going to receive other medication for blood pressure, etc., while hospitalized. Make sense? Okay. In relation with the severe preeclampsia, classically, you need to be able to recognize the symptoms of a woman with a severe preeclampsia. It is true that the blood pressure is going to be much, much higher than 140 over 100, but there are other symptoms that tell you that the preeclampsia is severe, and this is tested. The most important of all them is pain in the upper abdomen. Pain, no heartburn, pain, yes? Pain in the upper abdomen, in the epigastrium that is here under the xiphoid process, or the right upper quadrant. This pain originates in the liver, in the capsule of the liver, that gets very swollen and even develop bleeding in the severe preeclampsia. This pain is the worst scenario in preeclampsia. So if they make you choose the patient to be seen first, is a patient that has pregnancy. Of course, this is pregnancy toward the last trimester, no? Usually, the last part of the pregnancy. Pregnancy and a woman with epigastric pain. So memorize, please, for test purpose for Nclex, that a woman that is pregnant, we have that advanced pregnancy, and epigastric pain is a priority because it's a woman that is going to have seizures in any moment. Another concern is generalized edema. We already mentioned that in face, in hands, etc. And visual disturbances. In severe preeclampsia, the retina detaches, retina detachment. The retina detachment is not painful, but the patient loses vision, okay, loses vision. You need to know that to prevent the seizures, the woman will receive magnesium sulfate. When the woman receives magnesium sulfate, the normal value of magnesium in blood, which is 1.5 to 2.5, is going to be raised until 7, okay? No more than 7.5. And the purpose of elevating the amount of magnesium in the blood is that this magnesium is a depressor of the nervous system that prevents the seizures, and is the most effective in patients with eclampsia-induced seizures. When the woman receives the magnesium sulfate, because it is vasodilator, is going to feel flush. So heat and congestion, fullness in the face and the ears, it is normal. The woman is going to feel sedation. It is normal. Okay, but what the woman should not have is coma, so unresponsive, or respiratory depression, because the magnesium can depress directly the respiratory center. So we need to monitor respiration, okay, level of consciousness and respiration. When a woman presents arrest of the respiration, it's too late. So we cannot allow a woman receiving magnesium sulfate reaching a respiratory arrest because it's too late. For that reason, the way of knowing if the amount of magnesium is too high is checking the deep tendon reflexes. Deep tendon reflexes, or DTR, okay, is this jerk that we obtain in different joints, but especially in the knee, called knee jerk or patellar reflex. For this, we need something called reflex hammer. It's a rubber hammer, yeah, that is used to elicit the reflex. When a woman has preeclampsia, the reflexes are, mute this microphone, the reflexes are increased, okay? And when the woman starts receiving the magnesium sulfate, the reflexes normalize. A increased reflex is a reflex that is 4 plus or 3 plus. A normal reflex is 2 plus, okay? But if the woman receives too much magnesium sulfate, the reflex is going to drop to 1 plus or to 0. After the reflexes drop to 0 is when comes the respiratory depression. So before the respiratory depression comes the reflex 1 plus or 0. That's why it's so important checking the reflexes, because we can detect the toxicity, the overdose of magnesium through the reflexes even much before the respiratory rate occurs. That's the reason for the importance of checking the respiratory, the deep tendon reflexes every 15, 20 minutes in the woman receiving magnesium sulfate. The other parameter that is important is urinary output. If the woman is having less than 30 milliliters per hour of urinary output, which can happen in severe preeclampsia, cannot continue receiving magnesium, because the magnesium is excreted in the kidneys and will build up to toxic levels and will produce respiratory depression. Don't forget that if a woman is having a infusion of magnesium sulfate and you notice that the patellar reflex is 1 plus or 0, the first to do is to stop the infusion of magnesium sulfate. But if the woman is presenting respiratory depression, so the respiration is 8 per minute, for example, or very superficial, or the O2 saturation elevates, or the O2 saturation drops, decreases, so no elevate, or the CO2 elevates, then you need to add calcium gluconate, which is the antidote of the magnesium sulfate. So you should know that, and that's it. Don't forget that preeclampsia can become severe and can produce disseminated intravascular coagulation. Disseminated intravascular coagulation, you know that is an activation of the coagulation in all the body, in all the microcirculation of the body. And for that reason, there is necrosis of fingers and part of the body because obstruction of the circulation by clots in all the body. But at the same time, it is a consume. It is the client runs out of coagulation factors and start bleeding all over. This is called HELP, in which you have hemolysis, microangiopathic hemolysis, because in the little thrombosed capillaries, the red blood cells are going to be destroyed, hemolysis, elevated liver enzyme, because the liver is going to suffer the thrombosis, and low platelets, because the platelets are going to be consumed by the disseminated intravascular coagulation. It is called HELP for that reason, disseminated intravascular coagulation. A female client developed postpartum preeclampsia 24 hours after having her baby. Do you know this? That is a possible. Usually the preeclampsia is before having a baby, before delivering the baby, and the preeclampsia tends to occur in the last trimester. And once the woman has the baby, so the baby comes out, the preeclampsia start improving immediately. This is the 99% of the cases. But sometimes the woman had not preeclampsia while in labor, had the baby, and after having the baby comes the preeclampsia. It's called postpartum preeclampsia. Yes, is rare. It's not the most common, but it's possible. This is the scenario. A female client developed postpartum preeclampsia 24 hours after having their baby. So before having the baby and while having the baby didn't have preeclampsia, but one day after developed preeclampsia. Which of the following findings require immediate report? Blood pressure 130/90, proteinuria, epistaxis, magnesium blood level 7. What do you think is the concerning issue?
Epistaxis.
Sí, de vista sí.
Epistaxis, yes, because it translates that probably is having a disseminated intravascular coagulation and a health variety of preeclampsia. Make sense? It's a way of testing that. The nurse review charting on the unit. So is the chart nurse is supervising the charting in the OB area and is reviewing the charting on the unit. Which entry will be reported to the supervisor? So something is wrong. So look for something that is wrong. Client diagnosed with preeclampsia. Charted. Report of epigastric pain and nausea. Malo. Bad. Healthcare provider notified. Client is in active labor with contraction 5 minutes apart. Charted. Membranes are intact, ambulated in whole with assistance. Client 36 weeks gestation with history of vaginal bleeding and placenta previa. Charted, small amount of bright red discharge noted. Check for dilation and effacement. 4. Client undergoing induction of labor. Charted, taking clear liquids, bloody show present, husband at bedside. What is wrong here in these 4 chartings?
The 3, the vaginal examination with the previous placenta previa is a mistake.
Exactly. Okay, so everybody get the idea? In placenta previa, we cannot do vaginal examination. Nothing can enter in the vagina if there is placenta previa. Placenta previa is diagnosed with ultrasound. And when there is need of evaluation, a very careful speculum without digital manipulation should be done. Is a malpractice doing vaginal examination, digital vaginal examination in a placenta previa, because it can precipitate, okay, bleeding. Okay, so this is wrong. First, the number 1 is okay. The correct intervention having a patient with epigastric pain is to call the doctor immediately, because it is serious, as I said before. Client that is having, a normal contractions, okay, while in labor, okay, can ambulate. Meanwhile, the membranes are not broken. After the membranes are broken, ambulation could become risky because a prolapse of the cord can occur. And client who is having induction of labor, okay, can take clear liquids. Okay, clear liquids are allowed. Okay. Bloody show is this plug of mucus, bloody plug of mucus that the woman expel when the labor starts, and there is no problem to have husband at bedside. So remember, you have in the 3rd trimester 2 types of bleeding that are tested. There are more reasons for bleeding in the 3rd trimester, but those are the 2 ones that are usually tested: placenta previa and Abroxion placenta. Both present with bleeding at the last moment of the pregnancy. And the placenta previa is not painful. The Abroxion placenta is very painful. And this is the most important to differentiate. Placenta previa occurs when the placenta inserts and grows low in the way for the baby to live. So here is the baby, So if in the case that labor is allowed, the placenta is coming out first, and second the baby. This, if it is allowed to happen, imply the death of the baby and the death of the mother. Why the death of the baby? Because if the placenta live, okay, before the baby, and the baby is still inside the uterus, the baby will suffocate because baby breathes through the placenta. Now the placenta is out. And death for the mother, because meanwhile the baby is in uterus, okay, the uterus cannot contract. Yes, you know that after birth and after delivering the placenta, the uterus contracts intensively, and this contraction is what stops the bleeding that occurs inside the uterus after everything comes out. You need to understand the placenta is penetrating the walls of the uterus like the roots of a tree. And when the placenta comes out, there is left there a hole, a wound in the uterus that have a lot of blood vessels that can bleed horrors, can bleed a lot. But when the uterus, everything comes out, is empty, the uterus contracts. And this contraction is strangle the blood vessel and stop the bleeding. If there is a baby inside, when the placenta live the hole here, the uterus cannot contract and the woman is going to bleed to death. It's just something to understand why placenta previa cannot be left to have labor. So the emergency in placenta previa is initiation, spontaneous initiation of contractions. We cannot allow the placenta previa to have contractions because, you know, I already explained what is going to happen. That's why placenta previa is necessarily mandatorily a planned, a programmed C-section. Okay, the placenta previa that is in the Nclex, that is the central occlusive, the one that is in the mid of the way. Okay, and the other issue is that the placenta previa cannot be manipulated, so nothing can enter here in the vagina. Okay, because can produce the bleeding. The placenta previa, as I said, is diagnosed during the early ultrasounds, which is something that changed the prognosis of the pregnancy since invented. And remember that the placenta previa, there is no pain in the uterus. The uterus is not contracted. The presence of the placenta previa doesn't make the uterus contract, and for that reason, there is no pain in the uterus. And the bleeding occurs because sometimes there are little teeny blood vessels that are broken. So a small amount of blood can come out, okay, when there is placenta previa. So you have a small amount of bright red blood coming out, but without pain. Abroxion placenta is different. And by the way, abroxion placenta happens a lot when the woman has preeclampsia, but also can be traumatic. Don't forget that the trauma, a fall, a motor vehicle accident, etc., can produce abroxion or separation of the placenta from the uterus. Yes, and in the abroxion placenta, the problem is that while the baby is in the uterus and the placenta is in the uterus, the placenta separates. The roots of the tree separates, comes out, like when the hurricanes comes and the trees, you know, separates from the ground, from the soil. Yeah, something similar. So between the placenta, which is this pink stuff, and the uterus, which is the, I don't know what color is this, there is blood building up there. It's a hematoma building between the placenta and the uterus. At the beginning, the hematoma is small, but then start growing and separates as growing more placenta separates, more placenta separates. And this is what happens in the abroxion placenta, a separation of the placenta from the uterus while the baby is inside. Which consequences is going to have this for the baby? Catastrophic. If the placenta separates from the uterus, will not receive more oxygen, so the baby will have a severe oxygenation deficiency until dying. So the most probable is that the baby is going to die. Yes. And second, notice that in placenta previa, in the other case, meanwhile the placenta is not coming out because it's allowed to have a birth, the baby is okay. Okay, but here the baby is inside the uterus, is going to be in severe distress or even death. Second, for the mother, this separation and bleeding, this hematoma that forms here produces two stuff. First, the hematoma will irritate the muscle of the uterus, producing a sustained permanent contraction. It's not labor. Labor is a contraction that comes and lives, comes and relax. It's intermittent, yes? No, here is a sustained, permanent, continuous contraction. It's called uterine tetany. Uterine tetany, yes? And this is going to produce a lot of pain. So the uterus is going to be contracted, it's going to be hard, and it's going to be very painful. The uterus of the placenta previa, the other case, is soft, is not contracted, there is no contraction, and it's not painful. Could be bleeding, but not painful. The uterus of the woman with abroxion placenta is going to be permanently, continuously contracted and terribly painful. The baby probably is dead, and the woman could or not be bleeding. Because if the hematoma is between the placenta and the uterus, but has still not drained to the uterine cavity, there is no bleeding visible. but later could be bleeding. So it's viable. But the other consequence for the woman of this Abroxion placenta is that one, amniotic fluid, this amniotic fluid that is here, can enter in those open veins that are in the wall of the uterus, can be injected in the veins of the uterus. So now you have an amniotic fluid embolism. This amniotic fluid with baby's hair, baby's skin, calcium, Vernis caseosun, etc., poo, etc., is going to travel through the veins to the heart and to the lung, and is a pulmonary embolism by amniotic fluid that is going to behave similar to the thromboembolism. But at the same time, the presence of those substances activate the intravascular coagulation. So also we have a disseminated intravascular coagulation in clients with Abroxion placenta. So we saw that patients with preeclampsia, severe preeclampsia and HELP had DIC. But also we see clients with DIC here in patients with Abroxion placenta. So if you have a question in Nclex, okay, what are common causes of DIC? You have two, you know what DIC, disseminated intravascular coagulation, okay? You have as number one cause, sepsis is the most common cause. Sepsis is when a person has an infection. Many people in the world have infections, and those infections generalize and then produce a systemic inflammatory response called sepsis. And this sepsis produces DIC. But the second most common cause of DIC is OB, patients that are OB with those conditions, preeclampsia, severe preeclampsia or eclampsia, Abroxion placenta, etc. Are we good? So those are causes of DIC. You know that DIC, usually you see the patient bleeding. You say, why? Because it's running out of coagulation factors and platelets, because they use all the coagulation factors and platelets in this process. DIC is an emergency. It's a very bad condition that is a priority. Okay, you know there is a test. There is a test called D-dimer. Okay, that becomes positive when there are clots inside the veins and the blood vessels. Of course, in the DIC there are many clots inside the blood vessels. It's a disseminated coagulation. Yeah, intravascular coagulation. So the D-dimer will be positive. Another detail that is tested, okay? So that's the refreshment of the placenta previa and Abroxion placenta. A client in labor at 39 weeks gestation was admitted to the labor and delivery unit. The client is ambulating in the hallway to facilitate labor progression when she tells the nurse, my water broke. Which of the following should the nurse priority action? So what is the most important to do? Check the color of the amniotic fluid that is coming out. Escort the client to the labor room and assess fetal heart rate. Escort the client to the labor room and notify the healthcare provider that the woman is having a baby. Have the client lie on bed and check vital signs. What do you think is the most important in the moment, in the exact moment that a woman says, my water broke?
Check vital signs.
The vital signs are not affected when the water broke. Understand
Check
that
the color.
they understand that you have a baby, okay? You have a baby inside the uterus, you have a placenta that is well attached, and then you have a membrane that surrounds all this, and you know, a uterus that start dilating, no? They start dilating, okay? And remember that the baby is connected with an umbilical cord to the placenta. Okay, it's a little Picasso, this drawing, but have an idea. Baby, umbilical cord, placenta, and then there is a lot of amniotic fluid. The amniotic fluid is maintained there, while the placenta, the membrane, maybe the membrane is purple. The membrane is intact. Yes, membrane is surrounding all the baby, but it's internal. But once the membrane is broken, when this membrane is broken, all this amniotic fluid is coming out. So now it's going to be like a stream of amniotic fluid coming out with violence, especially if the woman is standing. And this is the moment in which this umbilical cord that communicates the baby with the placenta, and it's very long and is floating in the amniotic fluid, can protrude. So together with the liquid can leave the umbilical cord. So the umbilical cord that is connected with the baby and the placenta, a loop of this umbilical cord can protrude in the vagina, okay, in the moment that the amniotic fluid is coming out. Here is the ¿cómo se llama esto? The cervix, okay, the cervix of the uterus, okay, the cervix coming here. This is the cavity, and here is going to descend. Now that we don't have liquid, the head of the baby here, the head of the baby is going to descend and is going to make pressure. Is going to make pressure here over the umbilical cord. That protrude the umbilical cord. It's a pressure there. So now the circulation is going to stop. The vital sign of the woman will not modify in the moment that the membranes are broken. Yes? And necessarily broken membrane doesn't mean that the woman is having, the baby right now. Maybe it's going to take many hours to have the baby. So we can rule out, we can eliminate, check the vital sign, because I say it's are not modified. And we can wait, okay, to communicate to the healthcare provider. There is something that we can do independently before. And the two stuff that we do before, okay, should be between 1 and 2. 1, the amniotic fluid. The normal amniotic fluid is like the aspect of the water when you wash rice or when you wash oats. Okay, these are whitish, okay, aspect of water that had been used to wash oats or rice is more or less the aspect of the amniotic fluid. Has some clumps and is white. It's clear and white with white parts. When the baby poos, is having poo-poo, is having a bowel movement inside the uterus, then the amniotic fluid can it has a reddish brown color, and it's called meconial fluid. Okay, meconial amniotic fluid. This tends to happen before the rupture of the membrane. Can happen because the baby is having problems. When the baby is having low level of oxygen, when the baby is in distress, can have a bowel movement, and then can appear meconium in the amniotic fluid. But sometimes can happen spontaneously, especially if the baby is in bridge position, head up and butt down in bridge position, because the contraction of the uterus can produce the emission of meconial fluid. Meconial fluid is important to diagnose first because you need to check that the baby is okay, to check if the baby has late deceleration, bradycardia, or any manifestation of distress. And second, if the amniotic fluid is going to, remember that baby breathe in amniotic fluid, is going to have occasional respiratory movement and is breathing the liquid. It's going to complicate because the presence of the poo-poo in the bronchi, even if the poo-poo is sterile, has no bacterial, but can produce atelectasis and respiratory distress. But you have two problems. One problem is that in this moment, the umbilical cord is compressed because prolapse in the moment of the rupture of the membrane. And the other problem is the amniotic fluid could have an abnormal color because previous fetal distress or could be functional. So what is the priority in this case? Having the umbilical cord totally compressed without zero circulation, or having something that suggests fetal distress previous to the rupture of the membrane?
No, the fetal cordon.
The umbilical cord. Okay, so learn that it is a classical question in OB. Each time a woman, because all women will break the membrane in a moment, spontaneously or artificially. Each time a woman breaks membrane and the amniotic fluid comes out, there is a possibility that in this moment, because it's in this moment that it occurs, the umbilical cord can prolapse. For that reason, by protocol that we nurses need to know, each time that the water are broken, in the moment the water breaks, we need to check the fetal heart rate. We don't dig our fingers in the woman's vagina because once the membranes are broken, the digital vaginal examination is not recommended. Because remember, outside the vagina, you have the flora of the skin, even the E. coli of the perianal area. Here is the anus, and the entrance of the vagina is in the anterior part, side by side, yes? So if we introduce our fingers in the vagina, even with sterile gloves, then we can sweep, we can translocate the flora of the outside of the ring, the border of the vagina, to inside the vagina where you have already the membranes broken and an uterus, endometrium, and baby there that is sterile. So when the membranes are broken, the digital vaginal examination is avoided, especially by the nurse. Make sense? So we don't dig there. We don't open the legs of the woman proceed with a how you call that, flashlight. Okay, if there is a protrusion of the cord. What we do is just to check the fetal heart tones. If the fetal heart tones are affected, the fetal heart tones shows bradycardia, yes, is because there is a prolapse of the cord. This is the way of noticing, discovering if there is a prolapse of the umbilical cord. So that's why it is a classical question, and the right answer is cord decline to whatever it can be done to make the client rest and check the fetal heart rate. The fetal heart rate. A deterioration of the fetal heart rate suggests prolapse of the umbilical cord, okay? Remember that if there is prolapse of the cord, okay, that can be seen here, because when the membranes are broken and the leak comes out, then the umbilical cord can protrude, and then the head of the baby is going to fit in the bones of the pelvis, okay, and it's going to be like a wedge that can make pressure there. Immediately it happens, okay, the fetal heart rate is going to deteriorate. And you can diagnose that. If the fetal heart rate is normal, it's because it didn't happen, okay? Once the membranes are broken, we avoid, ambulation, because posteriorly the prolapse can occur. When a cord prolapse happens, we need to immediately separate the head or the presenting part of the baby from the cord. The easiest and remember that this test that we will have, Nclex, is an entry-level generalist nursing test, no specialist test. So for a nurse, new graduate nurse like you, the correct intervention is this, the knee chest position. Those are the knees. This is the chest. Yeah, this is the chest. So the purpose of this position is to make the gravity force, this arrow, this black arrow is representing the gravity force, pulling the baby in this direction, separating the head of the baby from the umbilical cord. That's why this is the correct intervention. An alternative could be a Trendelenburg position if the woman is unable to adopt this is unable to adopt this position. I know that sometimes you are going to read that the best intervention is to introduce the fingers and push the presenting part away of the umbilical cord, but we as entry-level generalist nursing, we don't know how to do that. So forget that, it's not in Nclex. What Nclex asks you, if what you do with the umbilical cord that is protruding in the vagina, if you push that back in the vagina, the answer is no. What you can do is to cover this with moist, sterile compresses to avoid the desiccation and contamination, and prepare the client for C-section after the physician is communicated. Is clear? Classical question, classical answer. When making assignments in the obstetrical unit, the charge nurse should assign the most experienced nurse to which client. G1PO, P0, reporting a small amount of pink vaginal discharge. Okay? One gestation, never had babies. Second gestation, had a baby, okay, reporting rupture of membranes with greenish fluid. This is the meconial fluid. G3, P2, at 7 centimeter dilation, 100% of effacement. The dilation is until 10, effacement until 100%. G4, P2 with bilateral 1+ pitting ankle edema, you know, is not important. So obviously the answer to this question, in this case, in this scenario, is the meconial fluid. This is the aspect of the meconial fluid. And as I said before, occurs when there is fetal distress, or sometimes when the baby is in breech position. So it's something that happens, okay, when there is fetal distress. Okay, and you need to know that labor has 4 stages: 1, 2, 3, and 4. The first stage is the longest and should last less than 24 hours. The first stage is since the moment that the woman has the first contraction, real contraction, no Braxton Hicks, real contraction, until the moment they have 10 centimeters of dilation of the cervix. So all those hours of contractions and pain of the first stage is just to dilate the cervix from 0 to 10 centimeters. First, the cervix is going to efface, is going to flatten, and then it's going to dilate until 10 centimeters. So one of the most common questions that I've seen in the first stage, what ends the first stage? And the answer is 10 centimeters of dilation. Or what separates first stage from second stage when the woman reaches 10 centimeters of dilation? As I said before, the first stage should not last more than 24 hours, usually much less, okay, much less. In the multipara, usually it's less than 12 hours. In the primipara, is usually less than 18 hours. But it's accepted that no more than 24 hours. The first stage is so prolonged, so lasting, that is subdivided in 3 phases: latent, active, and transition. And those phases are defined by the number of centimeters that the ¿cómo se llama? The cervix dilate. When you have latent, it's from 0 to 3 centimeters. Active, from 4 to 7. And transition, 8 to 10. So what I do, I memorize 4 to 7, because now I know how many centimeters need to be the previous and the posterior. Notice that you recognize the names because latent is something that is very slow. So it's at the beginning when the contractions are occasional and soft and not intense. Active is when they start, okay, the regular and continuous contraction. And transition, called transition because it's a transition from the first stage to the second stage. Okay, the maximum that should last a contraction is 90 seconds, and usually should be coming maximum every 2 to 3 minutes. At the beginning comes every 7 minutes, every 5 minutes, but then at the end, in the transition phase, is coming every 2 to 3 minutes, lasting a maximum of 90 seconds. Okay, a woman in these hours of labor can drink clear liquids. Clear liquids, you know what clear liquids, and should be encouraged to void every 1 or 2 hours. The distension of the blood is going to impede, is going to interfere with the labor, and should avoid, okay, the woman to be supine. You prefer the woman to be in lateral position. The second stage is since the moment that the woman reaches 10 centimeters of dilation of the cervix and the moment the complete baby is out. Usually is lasting less than 60 minutes. The third stage is when the placenta comes out, usually lasts less than 30 minutes. And the fourth stage is a couple of hours after birth where the woman is observed for bleeding. How can be tested that the woman is having 5 centimeters of dilation, in which stage and which phase is? Obviously, 5 centimeters is the first stage, active phase. This is one question in Nclex. A client with 35 weeks gestation came to labor room with membrane rupture of 18 hours. So what is the problem when the membranes breaks? This barrier that separates the flora of the vagina from the sterility of the uterine cavity is lost. The most common cause of infection in the uterus is an streptococcus called, or group B streptococcus called Streptococcus acalactiae. Okay, so it's an streptococcus, the most common. For that reason, a cultured test is done in the vagina in those scenarios. So this question says that the test for the streptococcus in vagina is not known yet, has not arrived yet. Which of the following nursing intervention has the highest priority? Monitor frequency and duration of uterus contraction, initiate prophylactic antibiotics, avoid vaginal examination, monitor fetal heart rate for late deceleration. What do you think is the most important in this scenario?
C.
C.
I think this is the answer. Because the most important is to avoid introducing an infection in this woman. Usually at this level, doctors initiate prophylactic antibiotics. But when I put in a balance, what is most important? Prophylactic antibiotics or avoiding introducing infection, the nursing intervention is to avoid introducing infection. So a nurse is allowed to do vaginal examination in a woman in labor. But then the same nurse should know that once the membranes are broken, this vaginal examination should be avoided because the risk of introduction of bacteria. Very good. Term pregnancy has been receiving oxytocin infusion for 12 hours. So a lot of hours receiving pitocin, oxytocin. Which finding requires immediate follow-up? So what's the question? Let's see if by strategies and common sense we can find the answer. A, one contraction every 5 minutes lasting 60 seconds. I said that the maximum, you need to memorize that, maximum is every 2 minutes and lasting 90 seconds. When you reach this value, one contraction every 2 minutes, and or lasting 90 seconds, the oxytocin should be stopped. because the maximum of acceptable contraction has been reached. If we continue giving oxytocin when this maximum is obtained, then we can produce problems in the baby or even rupture of the uterus, okay? So it's important to know that. But one contraction every 5 minutes, lasting 60 seconds, is still in the range of safety, in the range of we can continue with oxytocin. Monitor shows variability and deceleration concern, but coincident with the peak of the contraction. So how we call deceleration that are coincident with the peak of the contraction, we call that
Early acceleration.
early. And those are not concerning. Those are vasovagal reactions and are not concerning. Client complains of weakness, possible. Somnolence, it's possible. And slurred speech. The slurred speech is a little concerning. Cervical dilation, 8 centimeters, station does 2+. We study what is that. So by instinct and by strategies, what is the right answer here?
C.
C. C. Maybe we don't know why, but we know that somebody having a slurred speech is somebody having a neurological problem, you know? So this slurred speech is concerning because oxytocin is not a sedative that should be producing a slurred speech. So it suggests something neurological, yes? And the other options are acceptable and normal. What you need to know about oxytocin is that oxytocin can have antidiuretic activity. After receiving oxytocin for so many hours, the woman can develop a syndrome of inappropriate antidiuretic hormone. Because having the oxytocin antidiuretic activity, it being for so many hours, receiving that, then the patient can have this excessive antidiuretic activity. And this could be the cause of this alteration of the level of consciousness and this slurred speech, because you remember that this SIADH mainly manifest with brain edema. This is the rationale of the why is C. So remember that oxytocin is an uterus stimulant and should be given until the frequency is 2 minutes and the duration 90 seconds. There is a term that was in one question in Nclex that is tachysystole. Tachysystole is the name when the uterus contracts, receiving pitocin, receiving oxytocin, the uterus contracts more frequent than every 2 minutes, every minute or every 1.5 minutes. It's called tachysystole. This is no good. It can kill the baby because remember, when the contraction occurs, blood is not circulating in the placenta. And in this moment, the baby is not receiving oxygen. If the contractions are too frequent, then the baby is going to be in prolonged period of anoxia and can die, can be in distress or die. Of course, if the fetus is in distress, how we know that a fetus is in distress? First, late deceleration. Second, sustained permanent bradycardia. Yes. And meconial amniotic fluid. So those are examples of scenarios in which you can identify fetal distress. So for example, one question in Nclex, which of the following nurses is liable of malpractice? A nurse that initiates oxytocin in a woman which baby is having late deceleration. So we cannot start oxytocin if there are late deceleration. Remember that in late deceleration, the interventions are stop. S, stop pitocin, T, turn position, turn to the lateral, O oxygen P, called the physician. It's important that we have risk of uterine rupture. The uterus, which is a bag, okay, a hollow bag that inside have a baby placenta, can break, and then the baby can come out free in the abdominal cavity if there is a rupture. This rupture can be induced by the oxytocin, especially if the woman has a previous C-section. In the past, the woman has a C-section, has a scar in the uterus. The uterus can break at the level of the scar. It's very rare, but it can happen. Then water intoxication. That is because the antidiuretic activity of the oxytocin. And also oxytocin can produce, for the same reason, elevation of the blood pressure. Other medications that you need to know that in OB are part of oxytocin are the carboprost and misoprostol that are like the oxytocin uterostimulant, but those are prostaglandins. How you identify that are prostaglandins? You see prost, okay? And those medications can be used to make the uterus contract before labor, during labor, or even after birth. Terbutaline. Terbutaline together with magnesium sulfate. Terbutaline and magnesium sulfate, okay? Magnesium sulfate are tocolytics. Tocolytic means uteroinhibitor. So instead of stimulating the contraction of the uterus, stops the contraction of the uterus. So what is the action? What is the reason of giving either terbutaline or magnesium sulfate to a woman? Is to stop contraction. So when you have a threat of abortion, of miscarriage, or a threat of premature labor, doctor can decide giving terbutaline or magnesium sulfate to stop those contractions, okay? What you need to know that are what you need to know that can happen with my eraser. With oh, that's why. Sorry. What can happen with the terbutaline? Terbutaline is a beta-2 agonist. Is a family of the adrenaline. Can produce tachycardia, cardiac dysrhythmia, hypertension, hyperglycemia. What is the role of beta-metasone, which is a glucocorticoid in OB? Remember that is a stimulant of the lung maturity. It's given to the mother before birth of the baby to accelerate the production of surfactant in the lungs and improve the prognosis of the baby. What can be tested in Nclex? Make many questions of OB. That's why it's important to have this summary, this refreshment of OB. What you can have after birth. Breasts have something called engorgement. And they ask you, okay, women can have engorgement. Engorgement is nothing wrong, is nothing risky, but is uncomfortable. Has pain, has discomfort. So there are two possibilities in a woman with engorgement. The woman wants to breastfeed. Engorgement is that the breast become congested with lumps, painful and warm before the let down of the milk. So the possibilities are two. Woman wants to breastfeed or woman doesn't want to breastfeed. And the question in the English is very simple. If the woman wants to breastfeed, warmth, apply warmth in the breast and take the baby and put the baby to suck. This is the treatment of the engorgement if the woman wants to breastfeed. Warmth and put the baby to suction. If the woman doesn't want to breastfeed, then it's cold and don't touch the breast, especially don't touch the nipple. Yeah. So no hot shower, cold in any way, and not manipulation of the nipples. A firm bra, very useful. Another topic that is in Nclex. You need to know that normally, functionally, in postpartum, the temperature of the woman increases, but no more than 100.4. And you need to know that it's normal to have bradycardia in the woman after birth, as low as 50 beats per minute. It's not disease, it's okay, and will disappear. Orthostatic hypotension, of course, the loss of liquid. And then it is very important, a woman during birth, during the labor, and in the first 24, 48 hours after birth, have leukocytosis. It's a functional leukocytosis that can reach the level of 25,000. So a woman just had a baby, had 24,000 white blood cells. It is not the most concerning because it is physiological, is expected. The aspect of the uterus after birth is a very important issue because the main problem after birth is bleeding. Bleeding is the most common cause of maternal mortality in America. And the bleeding is associated with an uterus that is not contracting properly. So the uterus after birth should be contracted, should be hard, should be painful, especially. So should be firm, should be hard, should be painful. A uterus that is not firm, is boggy, is soft, and is not painful is concerning because it's a uterus that can allow bleeding. The height of the uterus is important. Should be no more than 2 centimeters, 2 fingers above the umbilicus, above the belly button. And immediately after birth, in the first 24 hours after birth. And then will decrease like 1 centimeters per day in the upcoming postpartum days. Summarizing, the uterus after birth should be firm, contracted, hard, should be painful, should be not too high, should be maximum 2 fingers, 2 centimeters above the umbilicus, and always in the center, should not be deviated to any side. If the uterus is deviated to any side, especially to the right, it's because there is an urinary retention. There is an acute urinary retention, and the urinary bladder is distended. And it's not rare that from happening because remember, epidural, opioids, and many other medications given during labor and birth, and the trauma of the vaginal birth can produce urinary retention. If the bladder is distended, the uterus cannot contract, and for that reason can start bleeding. This is the most important. It's very important, the detail of the uterus. When you have a uterus like this, if the uterus is deviated, make the woman pee, empty the bladder. And if the uterus is not well contracted and the bladder is empty, then massage the uterus to restart the contraction. Doctor will indicate the medication like oxytocin, carboprost, or basically carboprost or oxytocin to stimulate the contraction of the uterus. Lochia. Lochia is the secretion that comes from the uterus after birth. In the first 3 days, of birth is blood. So it's okay to have blood coming from the uterus in the vagina the first 2-3 days after birth. But the amount is important. The amount should not saturate. So saturate means that it's going to fill completely a perineal pad in 1 hour. If a perineal pad is saturated in 1 hour or less, it's too much. So the perineal pads can be saturated in every 2 hours, more or less. Make sense? And second, so any perineal pad that is saturated before 1 hour, need to check the uterus to see if it's buggy, is bleeding, is deviated, etc. And the other topic that is frequently in Nclex, all those have been questioned and very recent the question. When a woman is on bed, is supine, when the woman is on bed, okay, you have the, let me change color, you have the uterus, okay, you have the uterus, okay, and the uterus should be bleeding, okay, should be bleeding. But the vagina, the woman vagina has this shape, okay, this shape. So this shape. So here in this cul-de-sac, okay, this cavity that is here, okay, blood can accumulate, So when the woman gets up, now is going to have the vagina in this position. So this blood that was accumulating there is going to live in abundance because accumulate there after 1 hour, 2 hours of being resting on bed, and then get up because you want to go to the bathroom, and then the woman is going to have suddenly a gush, you know, a volume of blood, okay, coming out, and is going to be scared. But what you observe, one, this blood coming out that is abundant can even fall on the floor, stops. No more blood is coming when it is emptied. And second, the uterus is well contracted. So this is what tells you that you could be reassurant. You say, it is normal. It is normal. Yes, okay? So it is a very common question in the English. Later, the lochia becomes, okay, pink, serosa, and then transparent, alba. And it's okay. It's not important how many days. The most important you need to know, red lochia rubra, only 3 days maximum. It's important. And never the lochia is stinky. Smells like blood, smells like something, healthy. And never is fetid, okay? This is the most important to remember. A common question in Nclex is that you know that vaginal birth, especially if they used forceps, can produce a lump in the wall of the vagina that is very painful, is purple, and even difficult voiding. And it is a vaginal hematoma. So the question is very simple. No, the woman has those symptoms I described, and that is a vaginal hematoma. The intervention in those cases to report, doctor will decide, need to be evacuated or. Yoan, are you there? Can you mute the person that has the microphone open? Because I need to leave the PowerPoint to see that too. Thank you. So this is the vaginal hematoma. And please, a part of the bleeding that we already discussed, a part of the postpartum preeclampsia that we already discussed, don't forget that the postpartum frequently complicate with DVT and pulmonary embolism. So delivery and birth and C-section is a risk factor for deep vein thrombosis and pulmonary embolism. So any scenario of DVT that you already know is significant, okay? So a nurse is caring for a client who had the vaginal delivery 4 hours ago. The client has saturated the perineal pad in 45 minutes, so it's bleeding too much. In less than 1 hour, saturated the perineal pad. During assessment, the nurse notices that the client has a baggy uterus and is deviated to the right. This is the urinary bladder. Although the vital signs are stable. Which intervention should the nurse perform first? And what do you think is going to be first? If the A, because precisely the cause of this baggy uterus is the distension of the urinary bladder. The answer to this question is assist client to the bathroom to urinate. Okay, more or less like this is tested this topic. The nurse is performing a postpartum assessment 12 hours after the prolonged vaginal delivery of a term infant, which assessment findings should be reported to the healthcare provider immediately. A, complaints of discomfort during fundal palpation. You palpate the uterus, the fundus, and it's painful. Foul smelling lochia, oral temperature 101.1, white blood cell count 24,000. So you rule out 4 because you know it's normal, rule out 3 because you know it's normal, and then you rule out 1 because it's normal. So what is unacceptable? Foul smelling lochia. I hope that you have such an easy question in your NCLEX. But as I said, in NCLEX frequently the questions are very easy. The nurse is returning the result of a urine pregnancy test to the currently to a woman who is currently taking several medications, and the test is positive. Which of the following prescriptions are contraindicated in pregnancy cellular apply? Doxycycline, an antibiotic, family of the tetracycline, can be used in pregnancy?
No.
Why?
Teratogenic.
Because
It's not teratogenic. Produce malformation, o sea, produce a deterioration of the enamel of the permanent teeth of the fetus. So when the fetus have the eruption of the permanent teeth are going to come stained, deformed, because it's what tetracycline produces in the teeth. That's why neither in children nor in pregnant women, a tetracycline should be used. Okay. Apart of that, there is not other. Okay. Fluticasone can be used, yes or not?
Yes.
Yes. Fluticasone is a topical steroid that is used in asthma and allergic rhinitis. Even systemic glucocorticoids can be used in pregnancy. We have cortisone in our body. We have cortisol produced every day, yes? So glucocorticoids can be used if there is need, medical indication during pregnancy. Fluticasone has the advantage that it's a topical glucocorticoid. Fluticasone is the one that is used in asthma, for asthma, and allergic rhinitis, yes. Insulin aspart, yes or not?
Yes.
Yes.
Exactly. Any insulin can be used in pregnancy. Don't confuse that with the moment of labor. I already said, in this moment, need to be regular insulin. As any patient going to surgery, any patient having acute decompensation. Isotretinoin, what do you know about isotretinoin can be used in pregnancy?
No, it's highly teratogenic.
It's highly teratogenic. It's X. You know, it is the medication that we use for acne, which is wonderful, a derivative of vitamin A. But women taking this medication must be in 2 contraceptives, one barrier, one hormonal, to avoid pregnancy, and should even wait 3 months after discontinuation of the medication to become pregnant. Lisinopril, captopril, that's such a good blood pressure medication, can be used in pregnancy?
No, it cannot be used as well.
No.
Also are teratogenic and affects the development of the kidneys of the baby. Thyroxine, levothyroxine, can be used in pregnancy?
Yes.
Yes.
Yes, of course. If the woman has hypothyroidism, can be used. A woman who has C-section delivery 5 hours ago now appears anxious and reports shortness of breath. The nurse should assess for which priority problem or finding before contacting the healthcare provider. Cough, warmth and directness, elevated temperature, elevated white blood cell count, or incisional discomfort. What is the concern in the patient that after birth is having shortness of breath?
It
DVD.
can be
DVT. So
DVT.
one,
It's the first
cough, warmth, and redness. Okay, practically we already mentioned the most important about postpartum hemorrhage. Maybe a question that I saw once in NCLEX is, select of that apply. Which of the following could be causes that predispose women to have postpartum bleeding? And try to think the following, guys. When the uterus is overstretched, yeah, then can bleed because cannot contract after emptying. So if you have a macrosomic fetus, if you have the most common multi-gestation, have twins or triplets, yes, or when there is too much amniotic fluid, it's called hydramnios. Okay, this overdistension of the uterus predisposed to bleeding. The other cause of bleeding is using medications that are utero inhibitors, like the magnesium sulfate. So understand that when a woman has preeclampsia and must receive magnesium sulfate to prevent the seizures and finally deliver the baby, after delivering the baby is at the risk of uterine postpartum bleeding because the magnesium sulfate that the woman receives can be a utero inhibitor. Multiparity, a woman that had many babies, those women that like to have babies and have like 6 babies before, is a risk factor. The other is having a prolonged labor, prolonged third stage when the placenta takes too long to separate. It can promote bleeding. Infection is definitely a cause of bleeding. When there is infection inside the uterus by this streptococcus that can infect and produce endometritis, is a cause of bleeding. And of course, the presence of Abroxion Placenta and preeclampsia because the disseminated intravascular coagulation. Okay, this already mentioned. Okay, mastitis. The question in the mastitis is always the same. Guys, in Nclex mastitis, you need to continue breastfeeding. You don't interrupt breastfeeding, even from the breast with the mastitis, because you have infection in the breast. You continue offering the breast to the baby. The only concession is use first the other breast. So when the baby has a lot of hunger and is sucking very violently, do that with the healthy breast, just because the pain. Okay, but a part of that is going to continue breastfeeding. Usually doctors select antibiotics that are non-harmful for the baby if they are excreted in the milk. Okay, let's see this part of the question. The nurse documents this finding in a newborn fetus the first day of born. So I tried to reproduce what I heard that had been in Nclex. No? So the student had a picture similar to this. And how you document what you see in this picture. A, B, or C. Here is the answers. Prematurity, Babinski, acrocyanosis, hip dysplasia. Acrocyanosis. I don't know if you noticed that the color of those feet are different from the color of the thigh or the rest of the baby. So what you observe here, that the feet, you don't see the hands here, but it is acrocyanosis. They are, darker. They have cyanosis in comparison with the rest of the body. So you need to be able to identify acrocyanosis in a baby, in a picture. You get the idea? Okay, is acrocyanosis abnormal?
No.
It's a normal, but it's very often.
It's a normal finding in the first days after birth. But what means acrocyanosis? So now let's go to the other question. And what you do with this baby?
D.
Exactly. This baby is cold. And the best way of providing warmth of a baby, if the mother is there, is to put the baby in contact with the skin of the mother. Okay? So it is an example of 2 questions that have been in Nclex, and how could be? How could be? So now when you take the Nclex, you don't feel so surprised because now you know how they make the questions. You cannot say prematurity because there is nothing here that says prematurity. Prematurity can be seen as severe findings in the baby. One of them is the presence of these wrinkles in the soles but it's not the only parameter. Babinski, which is something normal in baby, is not explored. Even you see the flexion of this great toe here. So I don't see Babinski here, and it was not explored. And hip dysplasia, you cannot say that one extremity is shorter than the other because it depends on you need to straighten the legs of the baby and observe the height of the folds, the subgluteal folds and the groin folds to suspect hip dysplasia. So you cannot talk about the hip dysplasia in this. It's acrocyanosis, okay? So trying to make eye visual memory for acrocyanosis, and then the knowledge is that is expected in the first day after birth is not abnormal, but means that the baby is cold. So you need to put, socks on this baby and swaddle this baby and put the baby with the mother, or if the mother is not available, put in under the radiant lamp of the radiant lamp is called that. Okay, this is another manifestation of coldness. Okay, the mottling. Sometimes you see the word mottling. Okay, mottling. Okay, here is written. And this is mottling. This is another manifestation of the baby's cold. So remember that the priority of the baby, of course, is breathing. So airway and oxygenation is the priority. When the baby is born, since the moment that that takes the head out, you need to suction the mouth because it's through which the baby will be breathing. The baby will start breathing after coming out through the mouth when it starts, crying. The next priority, you need to understand this, after breathing, the next priority of a baby is to keep the heat, to avoid heat loss. And we nurses need to know that. Babies are at risk of hypothermia. Hypothermia can kill a newborn. Hypothermia occurs in baby first because they come wet. Remember, they come from a swimming pool. They come from a climatized swimming pool, a warm swimming pool. And now comes wet to an environment that is cold. The air in the hospital is cold. The temperature of your body is 98, yes? The temperature in your room, in your house in this moment is, I don't know how you have the temperature. In mine, I put that in 76. So 76 to 98 is a big difference, no? Okay, so now you understand that the air is colder than the body. And for that reason, they are going to. So what is the intervention to avoid the loss of heat through evaporation, which is what happens when you are wet and evaporate? Dry the baby, dry carefully, thoughtfully the baby. Then the other reason for losing heat is irradiation. Here, because precisely the air around you is colder than you are continuously irradiating heat to the air. And this irradiation makes you lose heat. Babies cannot lose this heat. Baby cannot afford losing heat like you can afford because you are adult. That's it. So you need to wrap, you need to swaddle. The baby cannot be left naked. And alternative is skin-to-skin contact with the mother, okay, radiant heat, etc., etc. The other form of losing heat is conduction. If the baby is touching a cold surface, the heat of the baby is going to be transferred to the cold surface. Cold surfaces can be, for example, the crib. Cold surfaces can be the how do you call that, the balance that you use to weigh the baby. Cold surface could be if you place the crib toward a wall that is an outside wall, and now in the north the temperatures are very low. Those are examples of how by conduction you can make the baby lose heat. And the last is convection. Convection is what happens when you turn on a fan and you refresh. When a fan is blowing the air, the room air on you, is removing the layer of warm air that you have around your body, because your body is 98, and then you warm by conduction the air, the layer of air that around you. But the fan removes this layer that is warmer and replace with a colder layer of air. Okay, this is the same. So you eliminate draft near the draft, corrientes de aire, no? The grip, and you avoid the outlet of the AC. You know, when you go to a restaurant and you sit in a table and then you notice that the outlet of the AC is over you, you say, no, change me from here. No, it's not comfortable. Okay. Hypoglycemia is the next priority. And we mentioned that hypoglycemia is more frequent in children of diabetic mother, for the reason we explained. But any newborn is at the risk of hypoglycemia. Guys, normally baby's blood sugar is from 45 to 70 milligrams per deciliter. If you in this moment have 45 blood glucose, you being on the floor, unconscious practically. Yes, normally babies are born in this range of blood sugar. So normally physiological, they come with low blood sugar. Makes sense? And for that reason, they're at risk. Any stress will make them reach low blood sugar. The way of avoiding hypoglycemia is early feeding. And they make the question practically. The woman is very tired, and when you bring the baby to breastfeed, the woman say, I know, bring my baby later, I'm very tired. What you need to explain the woman is important to have early feeding to avoid a common complication of newborn, which is hypoglycemia. The other cause of hypoglycemia is prematurity, low birth weight, sepsis. Those are also cause of hypoglycemia. A classical detail of hypoglycemia: babies with hypoglycemia are going to have a form of tremor, which is an equivalent of a seizure that classically is described as jitteriness. Of course, how you verify this hypoglycemia? Capillary blood sugar and prevention, early feeding. The Apgar. Sometimes you have question of Apgar. I don't think that you need to memorize the Apgar table, because very exceptionally I've seen that it is necessary to calculate the Apgar of a baby. But what I've seen frequently is that if they give you an Apgar score from 0 to 10, yeah, from 0 to 10, they ask you what can you do, what you need to do with this score. So this that you see here, I think is important, because it's the one that I see more frequently. So remember, when the baby is born, is not breathing regularly, is not using the lungs, the heart is totally different in uterus as the heart is when is out of the uterus. The circulation is totally different. So there is a transition that occurs in minutes from the intrauterus life to the extrauterine life. Okay, you need to know that they start breathing. They never breathe, and now they breathe, okay, efficiently. They expand the lungs, and they are going to stop receiving blood through the umbilical vein that, you know, is not arriving anymore to the right heart. So they need to close the communication between the right and left atrium, okay, the ostium secundum, and they need to close the communication between the aorta and the pulmonary artery. So they need to close the ductus arteriosus. And this is in minutes. It reminds me the Transformers, okay? I never pay attention to the transforming movies until the other day I was watching TV and I saw the transforming movie. And I saw was so funny how those cars transform in a human and then in a car. It's something like this, what happens in the moment of birth. So the classical question in Nclex that I see very repetitively, what is Apgar score for? And they give you a distractor. It predicts if the baby can have brain damage or if the baby can have cerebral palsy or if the baby is going to be intelligent or dumb or have learning difficulties. No, Apgar score only evaluate if the adaptation of the extrauterine life has been reached successfully. For that reason, because it's just for that, for the minutes immediately after birth to see if the baby adapts from intra to extrauterine life, this is the only purpose the Apgar score cannot predict anything else. For that reason, this test is done in the moment of birth and then 5 minutes later. So what is expected? That in the moment of birth, the Apgar score should be low. And at 5 minutes, higher improvement. If this tendency occurs, you say the adaptation to the extrauterine life is happening. That's why this is the answer to this question. It's a very repetitive question in Nclex. For what is Apgar score? What is the meaning or the application of the Apgar score? And that's the answer. Is just to evaluate if the transformation, the adaptation to the extrauterine life has occurred properly. That's it. In the Apgar score, you can have 3 levels of scoring. 0 to 3, critically ill, needs CPR, need cardiopulmonary resuscitation. 4 to 7, moderate distress, needs a stimulation, no resuscitation, just a stimulation. What is stimulation? Is tested. Rubbing with the towel energically the baby. And don't give, spank. Don't hit the baby because you go to jail. And suction the mouth and administer oxygen with mask. This is the interventions in 4 to 7. And 8 to 10, the baby is totally stable and is a baby that can be transported to the nursery. Okay, there is no need of a special intervention. I've seen those scores. Okay, so the baby is born with a score, Apgar score 5. What are the expected interventions? So dry thoughtfully the baby, rubbing energically with the towel, give oxygen and suction the mouth. The baby has 2 at the moment of birth, cardiopulmonary resuscitation. Okay, those are the most important. It's clear? I don't think it's necessary to memorize the Apgar score. It's very low probability that you have a question of doing that. If you know that already, no problems, because if you work in OB for a while, you memorize that. I never forget the Apgar score because in my rotation from OB, okay, you do that every day many times. It is not the purpose, but Apgar course is going to use the heart rate. Is going to use the respiratory effort. Something called reflex irritability, and something called muscle tone, and something called color, skin color. So 5 parameters, and you can have 0, 1, or 2. Okay, and the minimum is 0, and the maximum is 10. So, for example, if the heart rate is more than 100, you give 3. No, sorry, 2. Sorry, 2. Sorry for that. 2. Okay, because it's 0, 0, 1, or 2. So heart rate. If it is more than 100, you give 2. Less than 100, okay, you give, okay, it is less than 100. There, heart rate, but less than 100, you give 1. If no activity, so no heart rate is no heart rate, you give 0. Understand? For the respiratory effort, respiration, strong cry, strong cry, give 2. Weak cry, give 1. No cry, give 0. For the reflex irritability, how you explore the reflex, how the baby responds to a stimulus, okay? That generally is an irritant stimulus. Very simple. You observe what happens when you suction the baby. So in this case, what you are observing here, this nurse is suctioning the baby. The baby is making strong, okay, facial, okay, contractions, and even a fighting for that. When you have this strong reaction, you give 2 points. Strong irritability. When you have very mild, reaction, reflex irritability, like grimacing, something that is sneezing. No, sneezing is strong. Sneezing is strong. Grimacing, okay. Weak, okay. Reaction, you give 1, okay, with irritability. Then you have the muscle tone. Muscle tone is total flexion, like in this case, you see the total flexion, partial flexion, and absence of flexion. And the last is the color. So you have totally pink, you give 2. When you have acrocyanosis, you give 1. When you have total cyanosis, you give 0. So if this baby has heart rate 130, I give 2. If this baby has a strong cry, I give 2. Because it's mentioned here. If this baby, I can see the reflex irritability is very energetic, it's fighting with the poor nurses, it doesn't allow the nurse to suction, I give the maximum 2. The muscle tone, notice how flexed are the hips, knees, and even feet, This is the normal attitude in a baby that the brain is okay, the brain is oxygenated, total flexion. So I give it 2. So the one that is left is what? Color, no? Is color. How much I give color?
One.
Why 1?
Because
Okay, do you notice that this color is different from this color? Do you notice that the color of the hands is different from the color? So you have like a magenta or yes, violet color in the hands and feet compared with the definitively red and pink of the rest of the body. There is acrocyanosis, so you give 1. So the score is 9. It is an example. I don't think that is. Yeah, you need to memorize that because I don't think it's possible. It's probable. Possible is possible. Probable was the word. What is the indication for administration of phytonadione to a newborn of 24 hours? Increase albumin, the treatment of jaundice, prevention of hemorrhage, prevention of hypoglycemia. What is the answer of this question?
Hemorrhage.
Yes. So what is phytonadione?
It's vitamin K.
Okay, so if any one of you doesn't know that as he knows, in Nclex, they don't see vitamin K, they say phytonadione. Okay, this is the same of vitamin K. That's the trick. Yes, newborns can bleed. Newborns have a wound, is the umbilicus, but also have trauma in the head because the vaginal birth, etc. They can bleed. And newborns are physiologically deficient of vitamin K. Because meanwhile, they don't develop, the mother doesn't trespass or translocate her intestinal flora to the baby is not producing vitamin K in the intestine. Important amount of the vitamin K that you and me have is synthesized by the normal flora in the intestine. So independent of the amount of vitamin K that we consume as green leafy vegetable, we produce vitamin K in the intestine, and we have a lot of vitamin K coming from the intestine because the production, depending on the intestinal flora, the bioma that we have there. But babies are born with a sterile intestine. That's why I need to be given a dose of vitamin K to prevent neonatal hemorrhage, okay? And the name of vitamin K is phytonadione, please. Do you know that the umbilical cord should have 2 arteries and 1 vein? And if you don't remember, please make a happy face, okay? So let's see a question of delegation. The RN has assigned 4 newborns. Which newborn can be assigned to the CNA, to the unlicensed assisted personnel, to be bottle fed? You can delegate to a technician to feed a baby, to a nurse student to feed a baby. But of these 4 newborns, which one is stable enough as to be bottle fed by somebody that is not licensed like a CNA? What do you think? Read the options.
The C.
I agree with you. It's the oldest of all the babies. Yes, it's the oldest. Okay, have more than 24 hours. What you can assume in a baby that have more than 24 hours, that this baby had already been fed. Okay, and of course is able to feed, to drink without swallow, etc. Without. And the problem is jaundice. You need to know that the jaundice that is present after 24 hours is just treated with phototherapy, and it is a physiological jaundice. Because the first, okay, is going to be fed for first time. You don't know if able to feed without distress. The second is having a heart rate a little high for a baby that is at rest. You are concerned when somebody have a unexplained tachycardia. That's why B is a problem. That's the problem, guys. The normal heart rate in uterus is 120 to 160. Yes? After birth, when the transformer, the heart does the transformer stuff, the normal heart rate is between 100 to 160. But then you expect if the baby is resting, is sleeping, should be more to the 100 than to the 60. Now we have more than 160. So why? Why? There is a problem here. Need assessment, need follow up. And these have cleft palate is a specialty. The feeding is a specialty. And for that reason is a no-no. That's why I agree with you. And Nclex makes a lot of questions about the normal findings in babies. Just document that. Milia are those white spots, white pores, okay, that are consequence of the excessive production of sebum by the skin of the newborns. One of the most common, the Sacral Melanocytosis. In the past, it was called the mongoloid spot. It is not used anymore, this term, because from one side, parents can think that they are talking about Down syndrome, okay, and in the other part, they are have a racial profiling. It is true that the sacral melanocytosis, so remember that it's seen in the sacral area and in the gluteal area, has a gray bluish color, and is more frequently seen in certain races like Native Americans, Hispanics, okay, Asians, okay. Native American, Asian, and Hispanics have more frequently this sacral melanocytosis, okay, and has not implications. It's normal, and will disappear. Will disappear. Molding is the shape that adopts the skull bones that are movable, are floating to adapt to the birth canal, and is normal and no problem with that. Lanugo is this hair that is in the body that is more frequently found in prematures. It's normal to have gynecomastia, males and females, newborns is normal because the stimulation of the maternal hormones. Even menstruations is possible in females, newborns, because the maternal stimulation. This is something that can be present in the gums of newborns. Those are not teeth, are called Epstein pearls, and will disappear. In Nclex have been tested frequently, not frequently, recently, this sign. Sometimes newborns have vasomotor instability. Vasomotor means that the blood vessel can open and close, vasodilation and vasoconstriction. And this vasomotor tone is controlled mainly by the sympathetic nervous system. The activation of the sympathetic nervous system produces vasoconstriction, and the inhibition, vasodilation. Yeah. And sometimes, okay, the sympathetic nervous system is symmetrical, no, as dimorphal. Okay, so you have one here and one here. Sometimes there is different vasoactive by the sympathetic nervous system in each side of the body, and then you can have one half of the body with vasoconstriction and the other half with vasodilation. You can see that here, and it's called the Harlequin sign. Harlequin is I don't know, it's like a clown, the middle age, they have a dress that is half white and half red, and that's why it's called Harlequin sign. Frequently, babies have this red spot, or in the forehead, or in the neck, in the nape, and it is the telangiectatic nevi or nevi. This is normal and will disappear. Vernix gaseosa is normal. Is something that is more abundant in some children, less abundant in others. You don't need to remove all this, just the excess, and little by little will be eliminated. They ask you in English, what is the difference in color and aspect of the meconium and the normal feces in breast milk fed babies? Meconium is dark green, so pay attention. You can think that meconium is black. No, meconium is not black. It's not black like melena. It's dark green. If you see the borders, you notice that it's a greenish discoloration. This is the normal aspect of the meconium. And the baby that is breast milk fed, the poo, the caca, is gold yellow. Gold yellow. And you see like curds, you see like a seedy aspect. The normal reflexes of the newborns are tested. You need to know that. Motor reflex, I think that everybody knows what is motor reflex, also called startle reflex, that the baby, when a sound or a movement is perceived, will extend the two upper extremities and making like an U, and then tends to close that, okay? Tonic neck reflex, if you turn in the direction of the arrow that is shown here, the head of the baby will extend one extremity and flex the other, okay? Fencing position is also called, no? And gallant reflex, all those tests have been tested. That's what are here, guys, okay? So please try to read that several times until you memorize that. If you stroke the back of a baby, will flex the extremities in the side that you stroke and will stand the other side. So it's like a curve, no? Like a curve like this in the trunk, and flexion of this and extension of the others. Grasp reflex. If you place your fingers in the palm of a baby, the baby will grasp your finger. Step reflex. If you place a baby, a newborn, in the hard surface, they make steps. They start like walking. Babinski is normal until 1 year of age, and there is extension of the great toe with separation or fanning of the remaining toes. The previous reflexes, all the reflexes that are mentioned here are primitives and will disappear at 3 months. All these reflexes will disappear at 3 months, except the Babinski that will persist until 1 year. They give you a picture, and you need to point where the heel stick can be done in the shadowed areas, okay? Never in the center. This is the site of the heel stick. The difference between caput succedenians and cephalohematoma. Both are benign conditions seen in vaginal birth. Caput succedenian is swelling of the scalp, and cephalohematoma is a hematoma, bleeding, under the periosteum of one bone. Both are going to be palpated like a bump in the head and are benign, and the question in anchors that you parents are very concerned about this, and you can be reassured. This will disappear. This doesn't affect the brain of the baby. This is not painful. It doesn't hurt. The baby is not experiencing pain because those bumps, and you can be reassured. Which of the following findings require follow-up in a 16-hour newborn? Lumbosacral melanocytosis, Epstein pearls, light yellow discoloration on the skin, acrocyanosis. So you can eliminate, okay? Eliminate what you already know. What is the answer? C. Jaundice that appears in the first 24 hours is pathological. Jaundice that appears after 24 hours, and usually even after 3, 4, 5 days, is physiological. So remember that, because it's the trick to answer this question that is very repetitive in different presentations. Jaundice in a newborn that appears before 24 hours, bad. Jaundice after 24 hours, physiological. Okay, very well. The total bilirubin level of a 36-hour, so more than 24 hours, breastfeeding newborns is 14. Normal value 12. So the normal value of bilirubin in newborns is 12, but it is a little elevated and appears 36 hours again. Based on this finding, which intervention you do? Provide phototherapy for 30 minutes every 8 hours, feed the newborn steady water hourly, encourage the mother to breastfeed frequently, assess the newborn blood glucose level. Of these 4 interventions, what is the adequate to this jaundice that looks like physiological? Repeat. Phototherapy for 30 minutes every 4 hours is not correct, because phototherapy should be continuous. The phototherapy should be continuous, should not be interrupted, except that every 2 hours you remove the baby from phototherapy, remove the protection of the eye, change diaper, feed, and then cover eye again and put again in phototherapy. Phototherapy, while indicated, is continuous. It's not for 30 minutes every 8 hours. So it is a trap, it's a trick, it's a bad intention option. That's why it's not correct. The right answer is to know that jaundice, a part of phototherapy, but phototherapy well done, okay? A part of phototherapy is treated with hydration. And the only hydration that should be given to a normal baby, a normal newborn, is breastfeeding or bottle, but no water, no water. So B is incorrect. No water. Babies are not giving water, okay? The liquid, the hydration, the oral hydration in newborns is breastfeeding or bottle if the woman cannot breastfeed. Make sense? The answer is C. Encourage the mother to breastfeed more frequently. This question has been like 100 times in Nclex, okay, in different students, okay. Are we good? Is in the long-term memory? Okay. The core care, what you need to insist the most commonly is that you need to place the diaper, folded in a way that is not covering the umbilical cord to avoid maceration of the umbilical cord. And we don't use alcohol. I remember in the past we used to use alcohol to dry sooner the umbilical cord, but then it was discovered that it can promote infections. Okay, so no alcohol and other complications. And usually the umbilical cord is going to fall after 1.5 weeks. Okay, circumcision. The circumcision, when it's done, is going to require this dressing that is a petroleum gas to prevent the adherence of the diapers in the wound. And it's expected, it's normal, that a layer, a crust that looks like pus, okay, around the wound, it builds up. So a yellow crust is normal. A question in Nclex is, if the baby is going to circumcision, what analgesia is given? A, local lidocaine, local lidocaine gel. B, I don't remember exactly the name, dorsal penis blockage. Block, okay? C is an opioid. And D, sucrose. Sucrose in, how do you call that, pacifier? Pacifier, okay, pacifier. So if you have this question, a baby is going to have circumcision, is going to be cut, this jacket of the baby. And which of these 4 analgesia is the recommended and the accepted by the standard of practice?
The pacifier.
Eddie.
Correct. So any person that doesn't know that, don't fall in the trap of anesthesia, etc., because what is recommended by the evidence, okay, independently what you think, is the pacifier with sucrose, okay, or glucose, okay, glucose or sucrose, okay. And that's it, guys. This is what I have to you. Okay, I already published and Yoan kindly sent you the summary that I made here. Okay, of this is just to help in OB. So let's see what we do next on Thursday. What topic we cover in practice question. I transported here to this PowerPoint, the summary, the questions that I had, information that had been in English. Okay. Any question? Any doubt?
I have a question, Professor.
Sure.
I'm
Go ahead.
gonna send it to the chat. It's a long question.
No, I cannot see the chat.
Oh, you cannot see it?
No, I cannot see the chat. I have a presentation and I need to run through the presentation. I cannot see the chat. If you have a question, you can do that verbally.
Okay. The question. Okay, let me read it. 2 days post cesarean with on unilateral unilateral swelling, warm, and wetness to the left. And there's another question. Like I have four questions. They ask which
I definitively, Fedeline, I think that you need to mail me the question because I don't know what happened. The only thing that I hear is unilateral, unilateral, unilateral.
Oh, okay. Maybe
Something's happening with the sound of your computer.
Oh, okay. No problem. Thank you.
Okay, sorry for that. If somebody can, heard the question, can tell me because I couldn't understand anything.
No.
Any other questions? No? Okay, guys. If you don't have any question, see you on Thursday. It's okay?
Thank you.
Thank you, Professor.
Thank you, Professor.
Okay, thank you for your attention. And please study a lot. We need you to pass this Nclex and start working as a nurse. There is a lot of positions available in this moment. There is a lot of old nurses retiring. Please be motivated, have passion, and study a lot. This is your priority at this moment, okay? So work in your Nclex. Okay? So good night and see you on Thursday.
Thank you, Professor. Have a good night.
Good night. John, I'll send you the attendance.
Okay. Thank you.
Bye-bye.